Okay, so in this video, we're going to be looking at a couple of different senses. And the first is the vestibular sense, which may be a new one and some of you may not have heard of. Usually we think of the five senses, but technically this is sense number 6. So the vestibular sense is what contributes to the vestibular system. There are a few parts that make up this sense. The vestibular system is the part that contributes to our ability to maintain balance and body posture. So this is located next to the cochlea in the inner ear, and similar to the cochlea, it is an organ. Well, the organs in this system are filled with fluid, and they contain hair cells which respond to the movement of the head. And to gravity. So unlike the hair cells in the cochlea, which are responding to sound, these hair cells are responding to the movement of the head. So as we move, that fluid moves, which then moves the hair cells, and that then causes neurons to fire. So that's where transduction is happening for this sense. But as I mentioned, this is just one aspect of our vestibular sense. There's then proprioception and kinesthesia, which also influence our vestibular sense. So proprioception is the perception of our body position, so our perception of where our body is in space and the position that it's in. And then kinesthesia is the perception of the body's movement through space. So both proprioception and kinesthesia, these messages travel to the brain via the spinal cord. And then there's information from the brain that is then sent to the sensory organs of the proprioceptive and kinesthetic systems. So these systems are continuously working together to tell you about where your body is in space and to maintain this sense of balance and body posture as a whole. Now, if they don't work together, we start to see some problems that many of you probably have actually experienced before. So as a kid, you might have noticed if you ever span around in circles, or even as an adult, if you spin around in circles really quickly and then you suddenly stop, you will notice that you feel dizzy. Or maybe you've experienced feeling dizzy after being on a roller coaster. When you are spinning around or when you're on a roller coaster, the fluid in the vestibular system starts moving around, and because of the momentum, once you stop moving, the fluid is still moving. Okay, so you have the fluid moving and telling you that your body is moving, but your proprioception and your kinesthesia plus your visual sense are all telling you that you are not moving. And so because of these mixed messages, that is why you feel dizzy. This can also explain, for any of you that get car sick, again, your body is not moving. So you're receiving this message from your vestibular sense that you are staying still, but then your visual sense is telling you that you're moving. So again, you have these mixed messages. And that's why you may have heard, if you do get car sick, it's best to sit in the front and to look directly ahead, as far ahead as you possibly can. Because obviously, if you look directly at the things going past you, you really get that sense of moving, much more so than if you look directly ahead of you and kind of fixate on a point in the distance. The feeling of moving is decreased, the visual information changes, you're focusing on something that's fixed, and so you don't have such a big difference between that feeling of staying still and that sense of moving. And so that can help you feel better. Okay, moving on to touch. So when it comes to touch, with the other senses we've looked at, there's been kind of one type of sensory receptor, but with touch, there are many types of sensory receptors, and these are located in the skin. And they're each attuned to specific touch-related stimuli. So, for example, you have some that detect different amount of pressure, others detect things like stretch, see vibration, pain, texture, patterns. We have sensory receptors for all of these. We also have a number of free nerve endings that also have sensory functions. So this is how our sense of temperature works. We have these free nerve endings called thermoreceptors, and they detect information about temperature and send that message to the brain where it is processed, and we experience thermoception or temperature perception. Now, with all of this information, just like with the other senses, apart from smell, the first place they go is to the thalamus. This information can also go to the medulla, and then it goes to the somatosensory cortex, which we've discussed in chapter 3. So remember, that's in the parietal lobe, right behind the motor cortex, and that's what's involved in our experience of different sensations related to touch. So that's being processed there. We also have some other free nerve endings called nociceptors. These are not just in our skin, though. You also find these in our organs, in our bones, and these detect pain messages. Okay, so it is their job to send that information about potential harm to the brain. So that's called nociception, a sensory signal that's being sent to the brain indicating potential harm. Now we're going to talk about pain much more in the next slide, but I do want to distinguish between two types of nerve fibers that carry pain information, and you will need to know the difference between these on the exam. So we have fast nerve fibers and slow nerve fibers. If you think back again to chapter 3, when we learned about the structure of axons, you will hopefully remember that around the axon, or around some axons, is this fatty substance, okay, this myelination. And the reason that is there is it helps to speed up the transmission of messages between neurons. Okay, so if it's myelinated, it's going to send a message much faster than if it's not. That is the basic difference between fast nerve fibers and slow nerve fibers. Fast nerve fibers are myelinated, they can send their message much faster. And so these are involved in carrying messages about acute pain. So very sudden, sharp pain that comes very quickly and maybe goes fairly quickly. And so, for example, if you stub your toe, it's going to be your fast nerve fibers carrying that message. Slow nerve fibers are then unmyelinated, and because they don't have that myelination, they carry their message much slower. And so these are involved in carrying messages about more longer-lasting chronic pain. So let's say you have a long-term back injury that constantly causes you pain. That ongoing pain is going to be slow nerve fibers carrying that message. So pain perception is a little different to some of the other senses, because unlike with other senses, pain doesn't seem to have a distinct area in the brain where it's processed, and we also see really great variation in how people perceive pain. Partly that is the result of genetics. There are genetic differences in how we experience pain, but pain perception also depends on how the brain is actually interpreting pain signals, and that is influenced by various situational and psychological factors. So, for example, let's say you have a really bad knee injury, and that usually causes you a lot of pain. And then one day you're walking home late at night and someone tries to attack you. Hopefully this doesn't happen, but if it did, let's say you don't know what this person's intentions are. For all you know, you're in a life or death situation. Your perception of that knee pain will probably change, and you might not even notice it at all. Those pain messages will most likely switch off because in that moment, you need to be able to run for your life. You can't be held back by this really bad knee pain, and so that perception will change because in that moment, you need to be able to run. This would also explain people who sustain very severe injuries that they initially don't seem to notice, or they notice but they don't feel the pain. That's usually because they're in shock in that moment, and that shock is going to again change the perception of pain. Now, one theory that tries to explain these differences, is called gate control theory. This is based on the idea that gates are involved in the shuttling of information between the brain and the rest of the body. So in particular, the idea that pain signals have to travel through gates that open and close before it can reach the brain. Now, one part of this theory is that these gates can open or close to either increase or decrease pain when needed. So the idea is that they can close at times where we need to ignore pain, as in the examples I just mentioned, or they can then open when it's important for us to acknowledge pain. The other part of this theory is the idea that we can actually inhibit pain by stimulating other non-pain receptors. So, what do I mean by this? Well, pain messages need to get up to the brain through the spinal cord. And what this theory is suggesting is that along the way on this process, there are these gates that they have to pass through. However, there are lots of other sensory messages that are also trying to travel to the spinal cord as well. And the idea is that those messages compete with each other. And so the idea here is that if we stimulate other non-pain receptors around the area that's in pain, we can actually reduce the pain message by essentially inhibiting the signal coming from those nociceptors. You're basically creating competing information that will hopefully prevent that pain message from passing through these gates. So for example, if you stub your toe, if you rub your toe after or you put ice on it, that is going to send sensory messages up the spinal cord so that now instead of just the pain messages, you also have these other sensory messages trying to compete. And because of that, they can then inhibit the pain message and reduce the intensity of the pain. The other thing that I want to mention related to pain is this congenital insensitivity to pain, because you may have heard that some people are born with this inability to feel pain. That is a real thing. This is what it's called. And so this is a very, very rare genetic disorder that people are born with. They can still detect differences in temperature and also pressure. It's specifically pain that they cannot experience. Now, this might sound great, it would be so nice to not experience pain. It's problematic, and actually these individuals are actually have much shorter life expectancies and a much greater risk of injury. When you think about it, pain perception is extremely important. It's adaptive. It helps us to survive. And that's because it motivates us to remove ourselves from the cause of pain. You notice that something's hurting, you stop doing what you're doing. Or you notice internally some kind of pain. You go and get it checked out by the doctor. You get things identified and treated. If you don't have that sense, if you don't know that you're in pain, you're not going to remove yourself from the cause of pain. You're not going to go and get medical treatment to treat that pain. And so that's why you see this much greater risk of injury and a much shorter life expectancy. Also related to pain, but I'm not going to discuss this, I'm going to let you watch this video that does a very good job of explaining it, is phantom limb pain. So phantom limb is when people have either had a limb amputated or they've lost a limb through something, but it still feels like the limb is there. And this video will explain why that experience happens. But one of the main things I want you to be aware of on the exam is how it's treated. The treatment was developed by Dr. Ramachandran, who's based at UCSD. He wrote this book, Phantoms in the Brain, that I really recommend. It's a good book. But he was also the first to develop this very, very simple treatment for this. It's a mirror box. It's this mirror treatment, which you can see here. So he would have them the people put their hands in this box, and on one side would obviously be the arm with no hand or with no limb. On the other side would be the existing arm or hand, and in the middle is a mirror. So if you look into the mirror on the side where the actual hand is, it will look like there's one on the other side. So it gives this illusion that the person has two hands. He would then have them engage in exercises aimed at reducing pain with their existing hand. This seems to somehow trick the brain into thinking that the phantom limb is doing these exercises, and it does actually seem to improve people's pain. So just be aware of that treatment on the exam, but please do watch this video to better understand phantom limb.